was launched in August 2017, and the data freeze of this talk includes about 180,000 individuals. And those are fully genotyped, imputed with deep whole genome sequencing data, and phenotyped with electronic health registry data. What makes this project quite unique is that it's a true public-private partnership. The data is collected by biobanks across Finland and consists of existing legacy collection as well as new clinic-based recruitment. And the large scale of this project is really enabled by extensive collaboration with international pharma companies. The phenotypes are derived from national health registries dating back almost 50 years. What makes Finland especially suited for this type of project is its population history that's dominated by a strong founding bottleneck about 120 generations ago. And as you can see in this cartoon here, ultra-rare, many of them deleterious, alleles stochastically jump to high frequency in the Finnish population through this bottleneck, which results in what's commonly known as a founder effect. And this Finnish disease heritage is very well documented, and it applies predominantly to recessive diseases. The result is that the allelic spectrum for most Mendelian disorders is dominated by a single common mutation that survives the founding bottleneck in Finland. And that generates, of course, a unique opportunity to explore the impact of Mendelian mutations on a population level, as we have to genotype fewer individuals to reach significance. In the Finland data, we have 1,500 coding variants in ClinVar, that is disease variant database, that are at reasonable minor allele frequency and genotype or imputation quality to permit association analysis in Finland. And of those, 600 variants are previously hypothesized to cause disease, so they are either likely pathogenic or they have been labeled as pathogenic by at least one submitter. So you can see here that the majority of disease-causing ClinVar variants in Finland are actually in the low frequency range, so they would usually be filtered out in GWAS studies. So how is it possible to get all these pathogenic low-frequency variants into Finland if individuals are actually only genotyped and not sequenced? And the first answer is, of course, the Finnish founding bottleneck that enriches those rare disease variants to higher frequencies, as I said in the beginning. But then on top of that, the long haplotypes and limited diversity of rare variants enable to impute these rare variants quite nicely with deep whole genome sequencing data down to those low frequencies. So we then wanted to investigate whether those known disease-causing variants were actually globally associated with disease phenotypes in our data set. So we compared the top associated p-values of them to random sets of intergenic variants of same minor allele frequency and same 3 MB windows. And what you can see in this plot here, left for the dominant likely pathogenic variants, is that about 10% of them have at least one association below p-value of 10 to the power of -6, which is significantly more than random intergenic variants. So it's nice that we can sort of confirm this with dominant likely pathogenic variants, as this is what we would expect. But then we also see some signal for dominant conflicting variants and to some degree also for missense variants. However, surprisingly, likely benign variants were also enriched for phenotype associations globally. This phenotype association signal still holds when we look only at benign missense variants. You might then suspect that those benign variants are not actually causing those GWAS hits and are just hitchhiking along in linkage disequilibrium. So to investigate that, we looked into statistical fine mapping and looked which variants were in the so-called credible set, so in those set of variants that very likely contain the causal variant for a given GWAS hit. And we found that quite the opposite, benign missense variants were more often part of the credible sets than missense variants not in ClinVar, so more likely causal. we were also surprised to find that variants in recessive disease genes were globally associated with disease phenotypes. So the two takeaways from these analyses are, first of all, that benign variants are not necessarily non-functional variants. Secondly, we might suspect now that many recessive disease variants actually have effects also in heterozygous state. And I'm going to give you two examples for these two findings in the next slides. That variant is an example for a likely benign missense variant that nevertheless has an effect on a disease phenotype, and it's also very likely causing that disease association indicated by fine mapping analyses. The disease in question is characterized by a lack of noradrenaline leading to severe hypotension, so it's then biologically plausible that this variant protects from hypertension. And you can see in the survival curve that individuals carrying either the heterozygous or the homozygous allele are getting hypertension later in life compared to wild-type individuals. The variant is also a nice example for being enriched in Finland, so this enabled us to find this association with our sample size. The second variant is an example for a known disease-causing variant in a recessive disease gene where heterozygous carriers actually have a phenotype. And the disease in question here is xeroderma pigmentosum, that's characterized by a decreased ability to repair damage caused by UV radiation in the DNA. And it's not present in non-finished repeats. So biologically, plausibly then, heterozygous variant carriers actually have also a higher rate of skin cancer. And this association could be replicated in Japan, which is a nice validation. And in the survival curve here, you can see that heterozygous carriers also get skin cancer earlier than carriers of the wild-type allele. We next wanted to investigate whether there were any coding variants that had recessive or dominant effects in FinGen. So on top of the additive GWAS model that we ran already, the sort of classical GWAS model, we ran also a recessive model and a dominant model using the same method SAGE that we used also in the additive GWAS. Here you can see the p-values of the recessive versus dominant versus additive model of a given variant and phenotype in a 3D visualization. And I think it's quite clear that the majority of associations are additive, but there are also a few exceptions where the dominant p-value is actually 2 orders of magnitude lower than the additive p-value here in red, and also even more associations where the recessive p-value is 2 orders of magnitude lower than the additive p-value. In total, we have 134 recessive acting variants in 41 genes. So as we would have hoped to see, those 134 recessive associations are enriched for OMIM recessive disease genes. So I'm just going to give you a few of those examples. There are 19 in total, and one of them is SERPINA1 that's been linked to alpha-1 antitrypsin deficiency, and PHase1 has been linked to Finnish congenital nephrosis, and GJB2 to hearing loss. So the other half of recessive associations happens in genes that have not been linked to diseases yet. And I'm going to give you 2 examples here. The first example is a missense variant in the CASP7 gene that's coding for a caspase, and it's associated with cataract. The minor allele frequency is 1.5% in Finland, and it's also enriched in Finns. And it's significant with a p-value of 10 to the power of minus 16 in the recessive model, while it does not reach genome-wide significance in the additive model. But probably there's still some additive component to it, so it's not sort of black and white recessive, because also we find a significant genome-wide significant association with the similar phenotype disorders of the lens in the UK biobank. Nevertheless, it's quite penetrant for homozygous individuals, so by age 70, about 45% of homozygous carriers have developed cataract. The next is a missense variant in C10.90 that's associated with sensory neural hearing loss. It's enriched in Finns, but the allele frequency is still more on the rare spectrum, so it's just below 1%. And the association is really quite sort of Mendelian style recessive, so we would not have found this with the additive model. That also means, however, that we still need to find a way how to validate it. In summary, the Finnish bottleneck, population-specific reference panel, and electronic health record data permit us to systematically study the phenotypes of thousands of rare coding variants in FinGen. What we find is that ClinVar benign variants have an aggregate phenotype association signal, and that suggests that benign variants are not always non-functional variants. What we also find is that pathogenic ClinVar variants and recessive OMIM genes have global association signals. So that suggests that the heterozygous carriers of those recessive variants also have sometimes disease phenotypes. We then systematically perform recessive GWAS of coding variants and find known and novel recessive disease associations. I would like to thank the many people involved in the FinGen project, starting with leadership, thanks to Arno Palotti and all the others, specifically all the other team leaders. Here I would like to highlight Mitja Korki leading the analysis team. Within the analysis team, I would like to specifically thank Juha Karjalainen, who performed all GWAS. Thanks to the phenotype curation team, the Finnish biobank heads, of course, all the participants, all the farmer partners, and last but not least, Mark Daly for mentorship.
Thank you very much, Dr. Heyne, for a very interesting talk. We have a number of questions on the chat. One question from Jamie Ellingford is how you've normalized or enabled assessment of association with specific phenotypes where there may be huge heterogeneity. So basically, how have you looked at all these phenotypes?
So the phenotypes were curated by a phenotype, a whole team so there was an expert team for each phenotypes that are curating those phenotypes in those teams with clinical teams, so neurologists involved in the curation of the neurology phenotypes and so forth. So that maybe a quick answer to your question.
Sure. Now a quick next one. Of course, very interesting that you found that benign variants seem to have a non-functional, but do you know of any functional data to confirm what you find here?
We haven't zoomed into these data, these benign variants individually. In aggregate, we find association signal for them, and then we find that they're also more likely causing. So very often they're actually in the credible set. So after statistical fine mapping, so that sort of gives us the confidence to believe that they're actually majority of them are actually causal. But we haven't looked individually at functional analyses of these variants.
Okay, I think we have to move on to the next topic. Very interesting and really giving a lot of information about, let's say, all these rare variants and how they actually can cause disease, for example, in the carrier state. Thank you very much. Then we move to the next presentation by Dr. Steve Lincoln, talking about germline genetic testing following tumor sequencing in cancer patients that has a remarkable high yield of clinical important findings that inform patient care. Dr. Lincoln, the floor is yours.
Hello, everybody. My name is Steve Lincoln. Thanks to the organizers for accepting this talk, and thanks to all of you for being here, virtually at least. Today, I'm going to be telling you about germline genetic testing following tumor sequencing in a large cohort of cancer patients. Here are my disclosures, and here's what I look like if you want to imagine me standing in front of you in a lecture hall in a conference center in Berlin. It's been well documented that tumor DNA sequencing can encounter both somatic as well as germline mutations. Now, the type and rate of germline mutations that are uncovered in tumor DNA has mostly been documented through the application of paired tumor normal sequencing by major academic health centers using their internal laboratories, often under research protocols. However, in most routine cancer care, it's more common that tumor sequencing and germline testing are typically ordered separately at different times for different reasons and often by different clinicians. Now, because tumor-only sequencing cannot reliably distinguish between germline and somatic mutations, a challenge is presented. Namely, what should one do when tumor sequencing encounters what could be a pathogenic germline variant? Only recently have medical practice guidelines begun to address this topic, with recent publications from both the NCCN in the United States and, as we'll focus on in this talk, ESMO, the European Society for Medical Oncology, now suggesting that germline follow-up testing might be applied following tumor sequencing under certain circumstances. The ESMO recommendation is fairly specific, providing a list of genes that if mutations are encountered in tumor sequencing, germline testing might always be considered, as well as some additional genes where germline follow-up testing may be considered depending on the specific cancer type or patient age. The question that hasn't yet been thoroughly addressed in the literature is what is the clinical experience with germline testing following tumor sequencing in routine care? In our study, we considered a large cohort of over 2,000 consecutive patients who were receiving germline testing for hereditary cancer genes, who had a current diagnosis or personal history of cancer, and who previously had received tumor DNA sequencing as part of their care. This cohort was diverse in both cancer types, genders, ages, and the patients came from diverse clinical settings. In addition, the ordering clinicians provided diverse reasons for ordering these germline genetic tests. In many cases, these included tumor findings that had been identified and were potentially of germline origin. The germline test was being ordered to resolve that. Although in other cases, treatment guidance, surgical planning, personal or family history factors, or patient concern were cited as indications for the test. In some patients, there was a clear combination of factors, and in other patients, no specific reason for ordering the test was provided. So, what did we find? Well, of the more than 2,000 patients in this cohort, 31% were found to harbor one or more pathogenic germline variants in a known cancer risk gene, either a high penetrance gene, such as BRCA1, or a moderate penetrance gene, such as ATM. Note that we excluded low penetrance genes, low penetrance variants, and variants of uncertain significance from this study. Importantly, most of these germline findings were potentially clinically actionable per current management guidelines, precision therapy labels, or clinical trial eligibility criteria, at least within the United States. Pathogenic germline variants were found to be prevalent across all of the different cancer types represented in this cohort. These included the classical HBOC and Lynch syndrome associated cancers, shown here with stars, but also we found a quite high rate of patients carrying pathogenic variants across many other cancer types as well, as shown here. In addition, pathogenic germline variants were prevalent across all of the patient age groups represented in this cohort. There was some enrichment in patients whose first cancer diagnosis occurred between the ages of 30 and 39, but all of these differences were either of borderline or no statistical significance. Pathogenic germline variants were found in many different genes in patients in this cohort. Most of the findings were in BRCA1 or 2, PALB2, the Lynch syndrome genes, or the moderate risk genes including ATM and CHEK2. However, there was a very long tail, many other genes that also harbored pathogenic germline variants in these patients. Of course, the large number of positives in some of these genes undoubtedly reflects clinician ordering patterns in addition to actual prevalence. As expected, the fraction of findings that were determined to be of germline rather than somatic origin by the germline tests following tumor sequencing varied considerably by gene. So, for example, about 40% of the mutations in BRCA1 and 2 were determined to be germline, and 60% were determined to be somatic. Similar rates were observed across the Lynch syndrome genes, PALB2, and a number of others shown here. At the same time, most mutations, again as expected, in TP53, CDKN2A, CDH1, P10 were determined to be somatic. Genes such as RAD51C and D had relatively few mutations overall, although most of those mutations turned out to be germline. We retrospectively analyzed the clinical records for those patients found to harbor germline mutations to ask whether the ESMO criteria would or would not have recommended germline follow-up testing. What we found was that 82% of these patients who in fact had germline positive results would have had that test recommended, although in 18% of germline positives, the follow-up test would not necessarily have been recommended. Of note, only about a third of the patients who harbored germline TP53 mutations, for example, would have had a germline follow-up test recommended. One reason for this was that we often found pathogenic germline variants in genes that are not known to be strongly associated with the specific cancers that the patient was affected by. So, for example, we see BRCA1 and 2 mutations here across a range of cancers, including many that are not known to be strongly associated with inherited homologous repair defects. Importantly, 8% of the pathogenic germline variants in patients in our study were missed entirely by their tumor sequencing. They were reported as neither germline nor somatic mutations by that analysis. There are a variety of reasons for this. In some cases, it was as simple as the germline gene not being on the tumor test. In other cases, it was a clear technical limitation with the tumor test, generally complex variant types that are difficult to detect in FFPE specimens. In other cases, it was a variant interpretation difference between the germline and tumor testing laboratories. A number of patients in our cohort had complex cancer histories involving multiple primary cancers. Indeed, 11% of the pathogenic germline variants that we found were uncovered in patients only after they had presented with a second, possibly preventable, primary cancer. Consider, for example, this patient who had breast cancer at age 44, ovarian cancer later at age 61, received tumor sequencing of a specimen from their ovarian cancer. A BRCA1 mutation was found, which upon germline follow-up was determined to be a constitutional rather than somatic pathogenic variant. Like this patient, many of these PGVs, these pathogenic variants, could have suggested specific screening or risk reduction recommendations that could have altered the course of their cancer history had they been found earlier. In summary, our analysis of this 2,000 patient cohort found that germline testing following tumor sequencing often, about 31% of the time, produced findings that could impact patient care. This was true for many genes across patient ages and cancer types. We found that the ESMO follow-up testing recommendations are effective and captured many, about 80%, but not all of the germline positive patients. We found that tumor sequencing missed 8% of the important germline findings, and we found that 11% of germline mutations were detected only after that result could potentially have helped patients detect or avoid a second primary malignancy. In conclusion, germline testing following tumor sequencing is often medically valuable, that the current guidelines for such testing are effective, if however conservative, and that tumor sequencing is clearly not a substitute for germline testing in patients for whom a germline test is indicated. I'd like to thank all the wonderful people I've had an opportunity to work with on this study, including the folks at Invitae listed here, as well as Dr. Allison Kurian from Stanford University Medical Center and Amy Blanco of the University of California, San Francisco Medical Center. I'd like to thank all of you for your attention, and I'd be more than happy to take questions if that's technically possible.
Thank you, Stephen, for a very interesting talk. We already got a number of questions, and maybe to start with an easy, would you generally recommend to do somatic and germline testing at the same time?
That's obviously a good option and has many benefits. There are two reasons why it doesn't get commonly used. One is, or as commonly used today. One is cost. The other is the logistics in the clinical settings around getting patient specimens of, both an FFP specimen as well as blood to the laboratory at the same time, and also dealing with the various consent issues. That was actually well described in a session at this meeting yesterday.
And then maybe, so you were saying that you see different fractions for the different genes. Is there an obvious explanation for that? Different length, the tissues in which they are expressed, or something like that?
I suspect it has more to do with the actual effect of the gene. So, for example, TP53 is often mutated in tumors. More than half of all tumors are TP53 positive. Indeed, so many that we tend to see that underreported by physicians. When physicians see a TP53 mutation on a somatic test report, they seem to tend to think it's always somatic. Our tests, our results here show that is not always true, but that the TP53 mutations that confer Li-Fraumeni syndrome are indeed rare. Germline mutations, that is.
Great, thank you. I think we need to move on to the next speaker. The next speaker is a Young Investigator Award contestant, José García-Peláez, and the title of his presentation is the first genotype-phenotype study on European carriers of C10.1 Germline mutations. Thank you for your talk.
Hello everyone. Thank you so much for giving me the opportunity to present the first genotype-phenotype study on European carriers of C10.1 Germline mutations. C10.1 Germline alterations cause hereditary diffuse gastric cancer, which is the best characterized gastric cancer-associated syndrome. It predisposes for diffuse gastric cancer and/or lobular breast cancer. C10.1 Germline alterations explain 10 to 40% of families fulfilling SDGC criteria. Current SDGC criteria include 2 gastric cancer, one of them diffuse at any age, 1 diffuse gastric cancer before 40 years old, and personal or family history of diffuse gastric cancer and lobular breast cancer, one of them before 50 years old. Families carrying C10.1 Germline causative variants are offered preventive and surveillance measures. For diffuse gastric cancer, risk reduction gastrectomy is advised to both genders. For women at risk of lobular breast cancer, bilateral surveillance with MRI or prophylactic mastectomy are recommended. Clinical classification of C10.1 variants is challenging when clinical data is scarce. Also, there are uncertainties about C10.1 related phenotypes and age of onset. These limitations condition the rationale for clinical criteria design and management of families. Therefore, we aim to study C10.1 associated spectrum and age of disease onset to optimize clinical management. The specific aims of this project are 2. First of all, identify genotype-phenotype associations considering the molecular classification of the variants. And then, we aim to integrate in this genotype-phenotype analysis clinical variant classification. As the last aim, and in light of these genotype-phenotype associations, we wanted to reconsider SDGC current clinical criteria. All this work was performed under the collaborative environment of the ER Engine Turis, from which you obtain information of 854 families carrying rare C10.1 Germline variants from 10 different European countries. The first step consisted in the curation of the molecular classification of the variants, organizing them in 2 groups. Group 1 includes all truncating and missense variants with a frequency lower than 1%. Group 2 includes intronic, UTIs, as well as missense variants with a frequency higher than 1%. Then, we carried out the curation of the clinical classification of the variants. To do that, we curated manually each variant, according to the ACMG curation guidelines for C10.1 Germline variants. Regarding the phenotypes, we curated them for probants and relatives, nearly 2,000 in total. We divided them in 3 different groups: HGDC-associated phenotypes, HGDC-related phenotypes, such as gastric or breast cancer of unknown histotype, ductal breast cancer, and ovarian or colorectal cancer. All others were considered non-associated with HGDC. It's important to mention that Van der Post et al. 2015 clinical criteria for HGDC were taken into consideration along the entire process. Our first aim is to identify genotype-phenotype associations related to the molecular classification. If we analyze the phenotype distribution of probants and their relatives carrying group 1 variants, what we can see is that diffuse gastric cancer is observed in a considerable proportion, around 20%, with an average age of onset close to 40 years old, while lobular breast cancer accounts for 5% of all phenotypes, with an average age of onset close to 50. Our next aim was to identify genotype-phenotype associations considering both clinical and molecular classifications. After clinical curation, we observed that pathogenic and likely pathogenic variants were exclusively in molecular group 1, while 95% of benign and likely benign were allocated to group 2. In summary, all clinically actionable variants are found in molecular group 1. Indeed, clinically actionable C10.1 variants are mainly truncating, while VUS are mainly missense in frame insertion variants. Likely benign variants are all missense. So, we next explore the phenotypes presented by families displaying different types of molecular variants within group 1. In these next slides, I will present the relative frequency and average age of onset of phenotypes in probants and relatives separately. Full color indicates the percentage of cases fulfilling clinical criteria. Dots represent average age of onset, and the balloon represents the number of cases used to calculate average age of onset. In this case, for probants presenting pathogenic, likely pathogenic truncating variants and their relatives, we can conclude that the most common phenotype is diffuse gastric cancer, in a proportion of 40%, with an average age of onset below 45 years old. Lobular breast cancer is developed before 50, account for 10% of all probants and relatives. For those probants presenting few missense variants classified as pathogenic, likely pathogenic, and their relatives, what we can see is that most of them develop diffuse gastric cancer at an average age of onset of 45 years old. It's important to mention that all families fulfill HGDC criteria. As you can see in this graph, for probants presenting truncating variants classified as VUS and their relatives, the proportion of diffuse gastric cancer is similar to that of carriers of truncating pathogenic, likely pathogenic variants, even though the proportion of breast cancer without available histology, no clinical criteria, and over 50 years old is the most prevalent phenotype. For probants presenting missense VUS and their relatives, the scenario changes, as diffuse gastric cancer and lobular breast cancer become irrelevant phenotypes, while breast cancer without available histology, no clinical criteria, and with 50 years old or older become the most prevalent phenotype. In our third aim, we reconsider the HGDC current criteria in light of our findings on genotype-phenotype associations. We are happy that our work helped in the design of the updated clinical guidelines that are in place in Lancet Oncology. First of all, we reorganized the 854 families according to HGDC clinical criteria. Then, we adapted the molecular and clinical classification as shown before. As you can see, there are parogenic like the pathogenic variants, both in families fulfilling and in families lacking criteria. Among families fulfilling criteria, 88% of the probants carry parogenic likely pathogenic variants, while this number decreases to 13 in families lacking criteria. This enhances the value of molecular classification and suggests that the use of clinical criteria is useful to direct genetic testing in HDGC families and in order to identify high-risk patients. When considering probants and relatives fulfilling criteria and carrying pathogenic likely pathogenic variants, almost 50% of cases are diffuse gastric cancer, while only 6% are lobular breast cancer. This suggests a certain bias within the criteria against lobular breast cancer. If we analyze the average age of onset, for diffuse gastric cancer is 41 years old, and for lobular breast cancer, 48 years old. If we now do the same for probants and relatives lacking criteria and carrying pathogenic likely pathogenic variants, only 8% of cases are diffuse gastric cancer, while 24% are lobular breast cancer. The average age of onset for diffuse gastric cancer increased to 50 years old, while the average age of onset of lobular breast cancer remains in 48 years old. With this scenario, we wonder how we could deal with these 46 families. To do that, we tried to adapt the clinical criteria to accommodate these 46 families. As shown, we analyzed all the phenotypical presentations in our cohort and matched it with current clinical criteria and CDH1 likely pathogenic and pathogenic variant pickup rate. As you can see in the right column, the pickup rate increases if the age of onset of diffuse gastric cancer increases from 40 to 50 years old, if we combine family history of lobular breast cancer and diffuse gastric cancer, and also considering families or probants with histologically confirmed and early onset lobular breast cancer, even in the absence of diffuse gastric cancer. This allows allocating another 28 families to potential novel HDGC criteria. Regarding the general aim of this project, this study demonstrates that clinical actionable CDH1 variants are mainly truncating, and highlight the controversial role of CDH1 missense variants in HDGC. Regarding HDGC clinical criteria, it's important to mention that most carriers of parogenic likely pathogenic variants fulfill HDGC clinical criteria, reinforcing their use in clinical practice. Moreover, it supports 50 as the upper age limit for CDH1 testing. And finally, it supports widening criteria to accommodate family history of lobular breast cancer. To conclude, I would like to acknowledge the ERIC group at Ibatimub in Porto, my supervisor Carlos Oliveira and my co-supervisors. Also, all the Genturis members because you made this project possible. As well, the Solvardi project for the financial support, and all of you for your attention. Thank you so much.
Thank you very much, Dr. Garcia, for this very interesting talk from a very big collaboration of the ERN Genturis.
Yes, it was.
Questions on the chat, and one of the questions is whether ovarian and colorectal cancer can be considered as CDH1 associated phenotypes based on these data, as that was always controversial.
We cannot conclude that because we were in a very low proportion comparing them with diffuse gastric cancer and lobular breast cancer. So with this scenario, what we can conclude is that we can scatter off both ovarian and colorectal cancer, as well as other kind of cancers such as prostate, lung cancer and others. But the main point of this question is that, yes, we can scatter off both ovarian and colorectal cancer.
And a question from Dr. Tripathi, was there a genotype-phenotype correlation in families with pathogenic CDH1 variants but a lack of related cancers in the reported history? This could help tailoring management.
Sorry, can you repeat? Couldn't hear it really well.
Whether there was a genotype-phenotype correlation in families with pathogenic CDH1 variants but related cancers in the reported history.
With other related With other related phenotypes? Sorry.
Other related cancers.
Other related cancers? Yes. Okay. So there is no, because we couldn't see any correlation because the other cancers were in a very low, very low proportion, and we have concluded that there are a very high spectrum of different phenotypes in the other type of cancers. So we cannot conclude that they are in a very low proportion. So it's kind of other cancers. So.
And perhaps one last question from Dr. Rakefet.
Yeah.
Do you think CDH1 testing should be offered in healthy individuals who would like to know their personal cancer risk?
Yeah, definitely. If we study the family history of these programs, I think it's extremely important to follow this history of cancer history, and also try to keep this track of in the programs in order to carry genetic testing.
Sure. Thank you very much, Dr. Garcia, for this interesting talk and for answering these questions. We move to a presentation by Dr. Walsh. It's entitled Enhancing Rare Variant Interpretation in Inherited Arrhythmias through Quantitative Analysis of 5,182 cases from long QT syndrome and Brugada syndrome consortia cohorts and gnomAD population controls. Dr. Walsh, the floor is yours.
Long QT syndrome and Brugada syndrome are inherited cardiac arrhythmias that can affect up to 1 in 1,000 people, though prevalences can vary for different regions. These conditions can lead to ventricular fibrillation and are a major cause of sudden cardiac death in the young. Therefore, clinical genetic testing is important for both the diagnosis and clinical management of patients, and in particular for identifying at-risk relatives who may carry causative mutations. Though there have been many reported gene-to-disease associations for these conditions, rare variants in only 3 ion channel genes account for the vast majority of causative variants. For long QT syndrome, these are loss-of-function variants in the potassium channels KCNQ1 and KCNH2, and gain-of-function variants in the sodium channel SCN5A. Whereas for Brugada syndrome, loss-of-function variants in SCN5A are causative. These conditions are genetically very heterogeneous, with thousands of potential causative variants, the majority of which are missense variants. Variant classification, of course, is probably the most critical and challenging part of clinical genetic testing. Guidelines from the American College of Medical Genetics have now been widely implemented for this purpose. These provide a framework for variant interpretation, but one that requires adaptation and customization for specific genes and diseases. Importantly, these guidelines are quite stringent in defining pathogenicity, and this is particularly true for missense or non-truncating variants. For the ion channel genes that cause arrhythmias, functional assays through cellular electrophysiology are particularly informative for variant interpretation, but it's usually not practical to perform these in a clinical genetic setting. The challenges of variant interpretation for missense variants have been highlighted in a recent study which reassessed all published Brugada-associated SCN5A variants with contemporary ACMG guidelines. And these found that only 17% of these published variants could be classified as pathogenic or likely pathogenic. So for missense or non-truncating variants, different lines of evidence can be grouped according to how informative they are for variant interpretation and how often this evidence is likely to be available. So strong variant-specific evidence, such as co-segregation of a variant with disease and family pedigrees, or data from functional assays, provide the gold standard for classification, but are often not available, particularly for genetically heterogeneous diseases. On the other hand, supporting evidence such as frequency in the population and predictions from computational algorithms are non-specific and are insufficient to define pathogenicity. So to address this issue, you want to apply case control evidence from large cohorts that assesses the enrichment of both specific variants and different classes of variants in cases over controls. We believe that this gene and disease-specific evidence can be used to increase the sensitivity of genetic testing. So to do this, we've used data from the International Long QT Syndrome and Brugada Syndrome Genetics Consortia. These consortia bring together samples and patient data from many of the leading inherited arrhythmia centres in Europe and Asia, with the aim of providing the necessary scale and cohort sizes to explore the genetics of rare diseases like these. For long QT syndrome, we've got data from almost 1,400 probands of European ancestry and over 450 probands of Japanese ancestry. Each of these have had diagnostic sequencing of the 3 main long QT syndrome genes. For Brugada syndrome, we've got data from 2,400 probands of European ancestry and 935 Japanese probands, each of which has had diagnostic sequencing of SCN5A. This slide shows an overview of the proportion of European ancestry cases with rare variants in the 3 ion channel genes. As expected, we see a much greater yield of rare variants in LONC-QT syndrome compared to Brugada syndrome, given the fact that we know that this is much more of a Mendelian genetic disease. In total, over 80% of European ancestry LONC-QT syndrome cases have a rare variant in one of these 3 genes, compared to just 21% in Brugada syndrome. Across both conditions, however, the clear majority of rare and therefore likely causative variants are missense or non-truncating, and therefore those variants which are much more challenging to classify. Initially, we classified the SCN5A variants detected in Brugada syndrome cases according to a current implementation of the ACMG guidelines. This was done using Cardiac Classifier, a semi-automated application of the ACMG guidelines for inherited cardiac conditions, with additional functional data from 2 publications. The first is a curation of published functional data for SCN5A by Denham et al., and the second is a recent high-throughput patch clapping study looking at data from 84 SCN5A variants. The graph on the right shows the proportion of cases with truncating and non-truncating variants and the ACMG classification applied. As we can see, the vast majority of truncating or splice variants are able to be classified as likely pathogenic or pathogenic. In contrast, the majority of non-truncating variants are still classified as VOS or variants of uncertain significance. We observe a background rate of rare benign variants in about 1.5% of individuals, as seen here with the gnomAD data, and we would expect anything in excess of this to be disease-causing. Therefore, this data highlights a high degree of undercalling of pathogenicity with current guidelines, and therefore a high false negative rate associated with the current Brugada clinical genetic testing. We first looked at the enrichment of specific individual variants in cases, evidence which is covered by the PS4 ACMG rule. Now, most adaptations of the ACMG guidelines have defined PS4 based on numbers of reported cases and set fairly arbitrary thresholds for different evidence levels. However, having cohort data enables us to define statistically significant enrichment. Therefore, for each variant occurring in a minimum of 3 cases, we compare the case frequency with the appropriate gnomAD population data, so that's European cases versus non-Finnish Europeans in gnomAD, and Japanese cases versus East Asians. We defined evidence strengths based on the odds ratio, so an odds ratio greater than 20 gave strong evidence, between 20 and 10 gave moderate evidence, and between 10 and 5 gave supporting evidence. However, comparing frequencies of rare variants in cases versus gnomAD can yield very high odds ratios with very wide confidence intervals, so therefore we conservatively decided to use the lower 95% confidence interval threshold. In total, 108 variants are enriched in LONC-QT syndrome cases, and 48 variants are enriched in Brugada cases. Next, we sought to identify regions or domains in the 3 ion channel genes that are highly enriched in rare variants in cases, and applied this evidence to the PM1 rule as we previously described for hypertrophic cardiomyopathy. So for each gene region with a significant excessive case variance, we calculate the etiological fraction. This is essentially the odds ratio expressed as a proportion. The EF can be defined as a proportion of cases with a variant, where that variant will be causative, or the prior probability that a variant is pathogenic. And these EFs can vary quite a lot by region, domain, and also, as we will see, by clinical context. So we've incorporated this evidence into the guidelines as we previously described for HCM. So an EF of greater than 0.95, that's greater than 95% chance of pathogenicity, gets strong evidence. An EF between 0.9 and 0.95 gets moderate, and between 0.8 and 0.9 gets supporting evidence. So before calculating the etiological fraction values and applying the PM1 rule, we first need to define the population frequency for what we consider a rare variant. That is to identify the frequency threshold where we see the highest case control signal. So to do this, we tested various thresholds based on the published framework. This uses defined values for disease prevalence and genetic heterogeneity for the 2 conditions, and various estimates of penetrance. The graphs show case control odds ratios for the 3 genes and the 2 conditions, with the data binned by population frequency. We see the strongest case control signals with the rarest frequency bin, where we estimate penetrance of at least 50%. This corresponds to gnomAD filtering allele frequencies of 1.1 by 10 to the minus 5 for LONC-QT syndrome and 1.0 by 10 to the minus 5 for Brugada syndrome. Therefore, here we're really assessing ultra-rare variants. So we see substantial clustering of these ultra-rare non-truncating variants in arrhythmia cases in each of these 3 genes. It has been known that the transmembrane regions and certain domains within the N-terminus and C-terminus of the potassium channels are pathogenic hotspots. But now we can accurately calculate the etiological fraction values for these domains, which corresponds to prior probabilities of pathogenicity for rare variants which are found there. The data shown here is for European ancestry cases versus gnomAD non-Finnish Europeans. And you can see that there are substantial numbers of case variants for both Lonky-T syndrome and Brugada syndrome, which occur in these high EF regions, and therefore for which the strong PM1 rule can be applied. However, when using this type of evidence, it's critical to take into account the patient context. The etiological fraction values and the subsequent PM1 rules that are applied are derived from case control variant frequencies, and therefore any factors that affect these will affect the EF values. As an example, the Lonky-T syndrome data we have used here is from a cohort of definitively diagnosed cases. However, genetic testing for Lonky-T syndrome is often done on the basis of suspicion of disease, where there will be fewer actual cases and therefore a lower rare variant yield. So we also generated the EF values from the familial Lonky-T referral cohort, and we believe that these should probably be used in referral cases where the diagnosis is uncertain. For Brugada syndrome, we also see a much lower yield of rare SCN5A variants in Japanese cases compared to European cases, and subsequently more moderate EF values and PM1 rules. The diagnosis of Brugada syndrome also affects rare variant yield. Brugada is diagnosed with a type 1 ECG pattern, which can present either spontaneously or only after induction with atumelin drug challenge, and we see almost twice as many rare variants in spontaneous cases as those who are with an induced type 1 ECG pattern. Therefore, this generates higher EF values and a greater prior probability of pathogenicity. We then incorporated this case control evidence into the ACMG classification for the consortia cohorts by applying the new adaptations of the PS4 and PM1 rules. For the European ancestry Brugada cases, we were able to increase the proportion of cases with pathogenic or likely pathogenic variants from 5.7% to 11.7%, and reduce the proportion of cases with VUS from 9% to 3%. The effect on variant classification in Japanese Brugada cases is more modest due to the lower case control signal seen in these cohorts. For Lonky-T syndrome, we were able to confidently classify as pathogenic or likely pathogenic the vast majority of non-truncating variants in the two main genes, as KCNQ1 and KCNH2. We do still see a small excess of variants of unknown significance over the background rate of rare benign variants in gnomAD. However, it should be noted that we haven't included any family segregation or functional data in this analysis, as this data would need to be manually curated from published resources or from ClinVar entries. So to conclude, we know that the current stringent ACMG variant interpretation guidelines can lead to large numbers of variants of uncertain significance. For major disease genes, where we see a clear excess of rare missense variants in case cohorts or a control or population, this can equate to a high false negative rate for clinical genetic testing for these conditions. We've shown how using case control data from large disease cohorts can help to address this. It provides semi-quantitative evidence for both individual variants and ultra-rare variants in specific domains or regions of these major disease genes. Using this data, we can increase the sensitivity of genetic testing while maintaining both the stringent and evidence-based approach of the ACMG guidelines, as well as working within that framework. However, when using this evidence, the patient context is of course critical, whether that's the ethnicity or the population of the patient being tested, or certainty around phenotype or diagnosis. So it's critical to only use the most appropriate data and evidence for the patient being tested. I'd just like to thank Professor Connie Bazzina, who's been instrumental in leading the development of the International Genetics Consortia, as well as to my colleagues in Amsterdam and London who've been involved in this project and developing these methods. In particular, I'd like to thank all the members of the International Lonky-T Syndrome and Brugada Syndrome Genetics Consortia who've contributed the samples and the data that make this type of analysis possible, as well, of course, as the patients and the families themselves. Thank you.
Thank you for a very interesting talk. I think we're going to have our first question from Joris, because we were still waiting for some questions in the chat. Joris, go ahead.
Thank you very much. Yes, that's one of the pleasures of being a chair. You get a chance to ask a question while people are walking to their microphones virtually online. Dr. Walsh, I was wondering, your domain analysis doesn't seem to give a lot of added value. It seems like the risk goes from 0.88 to 0.9. And I was wondering whether it would be useful for these genes to look more at protein modeling and whether specific mutation sites within domains actually have a higher likelihood of being pathogenic, and that you see a different distribution between, let's say, gnomAD and the patient cohorts. Could you say something about this?
Actually, I think for a lot of the domains, we do actually see fairly strong EF values. So for the transmembrane domains, it does go up to about 0.8, 0.98, 0.99. So I think probably within this, we could even further distinguish between some more highly pathogenic variants versus those that have kind of lower probabilities. But in terms of applying the rules for this guidelines, I think for most of them, it works pretty well with the kind of one-dimensional approach.
Thank you.
Yes, thank you for the answer. Unfortunately, there's still no further question in the chat.
I have a question. I see a question actually that has been sent to me. Sorry, Martin, it's directly sent to me. Could you comment on the potential value of long QTS population screening based on these results?
So I think it's very important when you're talking about population screening that you need to be really careful about how you interpret the variants. So with these genes, we tend to see about maybe 1 to 2% of people will have a rare variant in one of these genes. So if you look at population screening, I think, and if you're trying to identify a causative variant, this kind of data, I think, you have to apply very carefully. And I think you'll need really strong evidence that a particular variant that you find in just an individual actually is pathogenic. So that's strong segregation evidence, strong functional evidence. But even then, you'd have to apply it, I think, in conjunction with like doing clinical testing and ECG tests.
Perhaps if I can ask another question, do you also, I mean, I have no idea, but do you also look for deletions or duplications in these genes as a potential effect of disease?
There can be. So I didn't really look at the kind of the truncating loss of function variants of this because they tend to be a lot easier to interpret. We kind of assume that a truncating loss of function variants actually do are pathogenic and do cause disease, and potentially larger deletions and things like deep intronic splice variants could be caused of as well. So it's possible that in an extra small proportion of cases that are currently genotype negative could have variants like that as well.
Great, thank you. So I think we're going to go on with the next speaker, another contestant for the Young Investigator Award, Gustav Ahlberg. The title of his presentation is Genome-Wide Association Study Based on Cardiac Magnetic Resonance Imaging in More than 20,000 Individuals Identifies 5 New Loci Associated with Left Atrial Enlargement. Thank you. The floor is yours.
Thank you for having me here to present this project. We have expanded the cohorts, so there's a slight change to the title. So let's begin with some background. It has been shown that atrial pathology has a significant impact on cardiac performance, arrhythmogenesis, and risk of stroke. Left atrial volume and function are also becoming increasingly recognized as biomarkers for prognosis and risk stratification. And left atrial enlargement and decrease of left atrial emptying fraction have also been independently associated with mortality in the general population. Patients with atrial fibrillation are frequently seen with enlarged left atria and dysfunction. And the left atrial size and function are also predictors for cardiovascular events in patients with atrial fibrillation. And it has been shown that left atrial volume is independently predictive of first ischemic stroke. Left atrial biomarkers can be assessed with echocardiography, cardiac computed tomography, or cardiac magnetic resonance imaging. Quantification of left atrial size and function is difficult due to its complex morphology and the influence of the pulmonary veins in the atrial appendage. However, the high resolution given by CMR imaging is considered the gold standard and yields very accurate measurements of left atrial volume, but it has had limited use. Moving on to methods. We used UK Biobank as a resource and performed genome-wide association studies on 7 left atrial phenotypes. These are left atrial minimum and maximum volume, and then the indexed left atrial minimum and maximum volume. We also looked at the left atrial function using left atrial total emptying fraction, left atrial active emptying fraction, also known as a booster pump, and finally left passive emptying fraction, which is a conduit function of the left atria. Here you can see a flowchart for inclusion of individuals into the study. The data set was divided into a primary and replication cohort. We excluded individuals with extreme BMI, myocardial infarction, or heart failure. After we had replicated findings from our primary cohort, we then merged the two datasets and performed our main genome-wide association study analysis. So here is a schematic overview for our analysis. First, we took the cardiac magnetic resonance images and applied a deep learning algorithm to segment out the atria. After that stage, we could then, perhaps a bit simplified, count the number of pixels in those segments and calculate the volume of the atria during one heartbeat. We then extracted our left atrial phenotypes of interest and performed the genome-wide association studies. After that, we then performed several post-analysis steps, such as L-square regression, transcriptome-wide analysis, conditional analysis, and Mendelian randomization. And here are the results. We included over 35,000 individuals with CMR images. The median age was 64 years old. Baseline characteristics matched quite well to what you would see in the general population in this age group. Mean BMI was 26, 2% had atrial fibrillation, and 1% had incident stroke. So, we identified a total of 16 unique loci. Some loci were associated to multiple left atrial phenotypes, as shown here in this figure. 6 unique loci were associated to left atrial volume, and 12 unique loci were associated to left atrial function. Here are the Manhattan plots for the maximum and the minimum volume. I would like to highlight the association of the CARP gene on chromosome 10. This locus was associated to multiple left atrial phenotypes and is also a gene that has previously been linked to cardiomyopathy. Also, quite interestingly, on chromosome 4 in the Manhattan plot for the maximum volumes, you have the PTX2 locus that has become known for its strong association to atrial fibrillation, and here it comes in just below the significance threshold. Moving on to the Manhattan plots for atrial function. The CARP protein was also associated with left atrial function, and notably calsequestrine, a gene that has been associated with atrial fibrillation, was associated to the booster pump function. Also titin, a well-known sarcomeric gene with a well-established association to dilated cardiomyopathy and atrial fibrillation, was associated to the conduit function. MEDAIC scan was used to investigate mediating effects of gene expression levels on left atrial phenotypes using GTEx version 7 tissue samples from the left atrial appendage and left ventricle. So we performed a transcriptome-wide association analysis on each phenotype, and we found that several genes were implicated by gene expression to left atrial volume and function. Among them were, for example, calsequestrine and aminopeptidase O, both of which have previously been associated to atrial fibrillation. There was also a long non-coding RNA called RP11-236B18 that had a significant association in several of these analyses. And this link RNA lies in close proximity to the CARP gene, so I speculate that perhaps this link RNA also regulates the transcription of CARP. Using the Bolt-Remel algorithm, we calculated the SNP heritability and genetic correlation of left atrial phenotypes to each other. Heritability estimates here can be seen in the diagonal of the figure, and as a reference, I have also added estimates from left ventricular ejection fraction and diastolic volume and end-systolic volume. So in summary, left atrial phenotypes had a SNP heritability of between 16 to 27%. Left atrial volume phenotypes were more heritable than the functional phenotypes, and the volume phenotypes were also very highly genetically correlated. However, the left atrial phenotypes are not particularly genetically correlated with left ventricular phenotypes. Using L-square regression, we then examined the genetic correlation to other traits, such as BMI, blood pressure, AFib, heart failure, and stroke. Atrial volume had a notable genetic correlation to AFib and cardiomyopathic stroke. Left atrial function was also correlated to stroke, and in particular we saw that passive emptying fraction was correlated to all-cause stroke, heart failure, and overall health rating. This suggests that passive emptying fraction perhaps shares some genetic etiology with some of the common cardiovascular diseases. We then performed a conditional analysis using MT-COJO, where we conditioned on atrial fibrillation and heart failure. And here I'm showing you the beta point estimate scaled in standard deviation. And I have listed the results for each sentinel SNPs associated with the respective phenotype. And none of the beta estimates here were mitigated more than the standard error of the original estimate, which is also shown here in the figure. And this suggests that these atrial volume and function loci are independently associated from atrial fibrillation and heart failure. And finally, we performed a Mendelian randomization analysis. This Mendelian randomization was limited by the lack of instruments and should be regarded more as hypothesis generating. That's a caveat I'd like to say before I present this. And this is also very preliminary data that I'm showing. Anyway, first we used the left atrial phenotypes as exposures on the outcomes stroke, heart failure, and atrial fibrillation. And this analysis suggested that primarily a reduction in the conduit function gives an increased risk of atrial fibrillation, ischemic stroke, and all-cause stroke. Also, increased minimum volume increases the risk of cardioembolic stroke. We then turned the tables around and used atrial fibrillation as exposure for the left atrial phenotypes. And these results suggest that atrial fibrillation increases your left atrial volume and reduces left atrial function. So I have speculated here that the reason for this might be that the underlying substrate really is an atrial cardiomyopathy, which gives a dysfunctioning atria and can give rise to the arrhythmia that manifests as atrial fibrillation. So, in summary, we identified a total of 16 unique loci. 16 loci were associated to left atrial volume, and 12 loci were associated to left atrial function. And I also showed that these loci are independently associated from atrial fibrillation and heart failure. Furthermore, I showed you that left atrial volume and function have a SNP heritability of 16 to 27%. And a Mendelian randomization analysis suggested that atrial fibrillation increases left atrial volume and decreases the atrial booster function. We are currently also generating zebrafish models now to further examine some of the loci that we have identified in this study. And before I end, I would also like to thank all my colleagues who also have been working on this project: Laura, Pia, Jonas, Jesper, Stig, and Morten. That's it for this presentation. Thank you for listening, and have a nice continued conference.
Thank you very much, Dr. Albrecht, for a fascinating talk showing us how important it is to have these large UK Biobank and GTEx data sets to really draw and learn a lot of new conclusions about genetics. And clearly you use very sophisticated machine learning approaches. So far, I see very few questions on the chat. I hope they're coming in. But perhaps could you speculate a little bit on, let's say, the quite many differences that you saw in genetic associations with the different traits? So there seem to be very few overlaps. What would be, from a clinical point of view now, the major conclusions from this work? Do you see things we can learn that we didn't know previously that were linked?
Well, I think that some of the differences comes from the volumes are actually maximum and minimum volume actually show very similar results. Maybe some variants are just on the border of being genetically significant or not, and then the minimum volume might be over and then the maximum volume might be under and so on. But they're very similar. And then you have the function. You're actually looking at maybe two different functions there, where you have the passive emptying fraction and the active emptying fraction. So they show some difference in their genetics. But I think the last question again. What we
no, it was more what let's say what your conclusions would be clinically from this work on looking at the different phenotypes and what genetics now has taught us. And I think your Mendelian randomization is showing some links between this, right? Is that correct?
Yeah. So I haven't the results from the preliminary are very preliminary when it comes to that. But I think it's interesting that I don't think that I believe at least that perhaps it's not your arrhythmia that actually increases your volume of the atria. So it might be something underlying there, something like an atrial cardiomyopathy or similar that actually gives a dysfunctional atria, and that would give you an arrhythmia as well as increasing your volume and decreasing your function. And that could be very interesting in terms of studying atrial fibrillation in the future, I think. Yeah.
All right. I'm just quickly looking at my chair in Berlin, here from Newcastle. Martin, you have any questions?
Yes, I would actually be interested in the machine learning or in the details of the machine learning a bit. And there's also another person that specifically asked what kinds of deep learning models he used. But I would also be interested whether the imaging was performed at only one site, and whether there's any batch correction that is required, and whether you can make sure that the deep learning model actually takes care of that.
So the deep learning algorithm itself is actually developed by a previously published article, and it's publicly available, so you can use this. We use that developed algorithm and annotate all the MRIs in this study. But it's a fully convolutional algorithm that has been developed, and it's been developed on the UK Biobank data as well. So that's why we also split this data set, so we can have a replication data set where it hasn't been used on. So yeah, basically.
And so the images come from all over Britain, or is that?
Oh, so if they come from all over Britain?
Yes.
Yeah, they come from the different UK Biobank test centers, and in the GWAS we correct for use that as a variable. Yeah.
Okay, thank you very much, Dr. Albert. Then we move to the last presentation in this session from Dr. Simon. And the title of her talk is Genetic Interactions Modulate Lipid Plasma Levels and Cellular Uptake. Dr. Simon, the floor is yours.
Hello everyone, I would like to thank for the opportunity to present our study focusing on genetic interactions modulating lipid plasma levels and cellular uptake. Coronary artery disease is a leading cause of death worldwide. It is triggered by atherosclerosis of the coronary arteries, namely buildup of the plaque consisting of fat, cholesterol, calcium and other substances, which leads to the restriction of blood flow to heart. A chief risk factor for developing CAD is hyperlipidemia, with blood levels of circulating low-density lipoprotein cholesterol being tightly linked to disease risk. That is why a lot of therapeutic efforts have been directed towards agents reducing LDL cholesterol. Evidence from more than 20 drug classes clearly show that reducing blood LDL cholesterol reduces the risk for vascular events, and that the stronger the LDL reduction, the stronger the relative risk reduction. The most pronounced impact on LDL cholesterol is achieved by combination therapies, for example, PCSK9 inhibitors that are given on top of statins. Most recently, siRNAs have been introduced to the armory of lipid-lowering drugs, with inclisiran, an siRNA against PCSK9, showing a persistent reduction of LDL cholesterol when given in combination with statins. Now the question is, how can we predict combinations that will exceed standard of care? An attractive approach to prioritize optimal target pairs would be to leverage gene-gene interactions, both additive and non-additive. Additive gene interactions are the ones for which the cumulative effect would represent the sum of effects from each gene or variant individually, whereas for non-additive GIs, the combined effect will be different than expected one, meaning different than a simple sum of the effects, and can be either buffering or synergistic. Now the question is, if we can use genetics to prioritize gene pairs that when jointly modulated will show the greatest therapeutic benefit. In order to address these questions, we focused our analysis on 30 high-confidence candidate genes from 18 genomic regions associated with blood lipid levels or the risk for CAD. Previous study performed at EMBO, which functionally analyzed 133 genes from lipid GWAS loci through RNAi-based knockdown experiments in cells, identified 28 of the selected 30 genes to modulate LDL uptake, free cholesterol levels, or LDLR, mRNA, or protein levels. We then conducted 3 independent sets of analysis to search for pairwise interactions of these genes. First, we extracted protein truncating variants from whole exome sequencing data of 200,000 individuals from UK Biobank. Second, we used GWAS lead SNPs from more than 370,000 participants of European ancestry in the UK Biobank. And last, we conducted systematic RNAi-based combinatorial knockdown experiments in cell models. The genetic data was provided and analyses were conducted by our collaborators at Biogen. To identify pairwise additive or non-additive genetic interactions, we applied robust linear model fitting for 4 plasma lipid parameters and also for CAD. We then integrated the functional and genetic data in order to prioritize the most promising gene pairs. Genetic data for this study has been generated from UK Biobank samples. UK Biobank is a major health resource allowing study of the long-term effects of genetic predisposition and environment on disease development. The initiative has recruited 500,000 participants aged between 40 and 69 years across the UK, who provided blood samples for future analysis and detailed health information for research purposes. Our collaborators at Biogen, together with several other companies, have formed the UK Biobank West consortium with the aim to exome sequence the entire cohort. At the time of our study, WES data from 200,000 participants had been completed, with an additional 100,000 available to Biogen for replication analysis. For the first arm of our genetic interaction study, we focused on protein truncating variants extracted from 160,000 exomes from non-consanguineous UK Biobank participants of European ancestry. Within our selected 30 lipid genes, there were 755 rare PTVs, which were used to conduct gene-based pairwise PTV burden interaction testing. At this sample size, 2 gene pairs, PCSK9 ApoB and LPL ApoB, met the stringent criteria to be classified as additive genetic interactions. Initially, at 160,000 sample size, LPL ApoB pair had been classified as marginally significant synergistic non-additive genetic interaction. However, replication analysis in another 79,000 exomes led to reclassification as an additive GI. Our study thus demonstrates the existence of high-impact PTV burden-based additive genetic interactions between lipid genes that, interestingly, are already targets of approved drugs, while non-additive GIs remain elusive despite of our substantial sample size. Then we performed pairwise SNP-SNP interaction testing of 28 lipid-cut GWAS lead SNPs, which were representing the 30 candidate genes. Unsurprisingly, this analysis detected a large number of additive GIs, indicated here in circus plots in gray. SNP-based analysis also identified non-additive GIs for all lipid traits tested, but not cut, indicated in colored lines. The strongest driver of these interactions came from the chromosome 19 locus, encompassing among others ApoE, which contributed to 19 of the 26 non-additive GIs. 6 non-additive GIs were identified between SNPs located in trans. As an orthogonal approach to genetics, we complemented UK Biobank analysis with systematic combinatorial RNAi screening in cells. Specifically, we monitored how the pairwise knockdown of the lipid genes with sRNAs impacted endocytosis of LDL by LDL receptor, main pathway responsible for efficient LDL cholesterol clearance from blood. In our assay, LDL is fluorescently labeled, which allows for quantitative readouts under the microscope. For this, sRNAs targeting different genes were spotted in a pairwise manner on 384 spots in a single-chamber sRNA array, on which cultured HeLa cells were solid-phase reverse transfected. LDL uptake was measured per cell and quantified from high-content microscopy images using automated image analysis. As for our genetic GI analysis, we applied linear model regression fitting to test for the genetic modifiers. In total, we tested 435 gene pairs, and results of these are represented on this heat map, showing either decrease in blue or increase in red of LDL uptake. We identified 35 statistically significant non-additive genetic interactions. From these, 20 were validated through independent small-scale experiments. Of the 20 non-additive GIs, 6 were scored as synergistic, which means simultaneous knockdown of both genes magnified the effect beyond expectations. And 14 non-additive GIs were categorized as buffering, which means relative to an additive effect, the joint knockdown mitigated LDL uptake in cells. As one example, our functional analysis identifies synergistic non-additive genetic interaction between ApoB and HMG-CR, joint knockdown of which resulted in a further potentiation of LDL uptake beyond the sheer additive effect. This finding was consistent with the gene's respective biological function in maintaining cellular cholesterol homeostasis. As another example, we identified buffering effects for LDLR and its adaptor protein knockdowns, confirming the predominant role of LDLR in LDL cholesterol endocytosis. Next, we integrated genetic and functional results. 12 of the 18 gene pairs nominated through SNP-based interaction testing as additive GIs for LDL and total cholesterol also scored as additive GIs for LDL uptake, 5 of which involved HMG-CR and 4 LDLR adaptor protein 1. 2 gene pairs, interestingly, SORT1 and TOM40 and NCAN TOM40, scored as non-additive genetic interactors both in the SNP-based as well as the RNAi-based interaction testing. Interestingly, TOM40 resides in the chromosome 19 locus together with ApoE. In the detected overlapping non-additive GIs, TOM40 exerted buffering effect in both gene pairs. This observation could not be explained by an off-target effect of TOM40 sRNAs on ApoE, suggesting that TOM40 contributes to the genetic interactions independently of ApoE. In conclusion, we have conducted an extensive exome, GWAS, and RNAi-based analysis to systematically test for additive and non-additive genetic interactions between 30 lipid GWAS genes on blood and cellular lipid levels. We detected pairwise effects indicating complementary biological mechanisms, and what was clear from our genetic data is that additive GIs were common, which supports the hypothesis that additive GIs between GWAS loci are pervasive and in combination modulate complex traits, whereas non-additive GIs were less abundant or absent from PTV burden analysis, confirming that for rare variant genetic interaction analysis, a very large sample sizes are required. The predominant driver of genetic interactions was chromosome 19 locus, with number of genes including ApoE and TOM40. To conclude, our systematic and integrative approach have led to identification of distinct gene pairs which can be considered as possible drug targets in lipid-lowering therapies. With this, I will end my talk, and I would like to acknowledge people from EMBO responsible for RNAi work and integration of the data, and Heiko's team from Biogen for genetic data analysis. And I would like to thank you for your attention.
Thank you for the very interesting talk. We have a few questions. Maybe I start out with one that I had in your conclusions. You said that you can conclude something about the biological function of these genes. And I was wondering if when they're in the same domain, when they're so close to each other, can you really conclude something about their function and not just that their expression is influencing the openness of the region and thereby the expression of the other gene?
So, for example, so first of all, I would like to apologize for a couple of graphs missing there. I don't know what happened because it's there still on my presentation. But coming back to the biological function, yes, you're right. So if we have SNPs in a particular loci, we actually don't know on what do they exert the function. But that's why I wanted to draw the attention to the ApoE locus and in particular TOM40, because they're usually associated together, for example, with Alzheimer's disease, and the same goes for the lipids. Usually the ApoE is the driver, but here we clearly see that if we knock down the TOM40, we don't have the effect on the ApoE expression, but we have the effect on the LDL uptake. And this is in particular interesting because it shows that it's not only one gene within a locus that can give you the effect from the GWAS that you see in the GWAS studies, but actually it can be that you have more pleiotropic loci where multiple of genes contribute to the final effect.
Thank you. And then there was a question from the audience about in the cell type in which the RNAi experiments were performed and whether you think that had any impact on your results.
Yes, so what we did, we used the HeLa Kyoto cells that we use standardly in the lab, and we've been able to replicate number of the results that you can expect from the knockdown of the key regulators of the lipid homeostasis within the cell. So we're quite confident that they're good to use for the screening approaches. Obviously, this is uncomparable to multicellular organisms, but they can give us the basic biological function of the information about the basic biological function of the genes.
Maybe related to that, there was also a question about whether other phenotypes could be screened or whether LDL protection yield different hits to clearance. I think this is maybe in line with that. So your cell types, can you measure something else on these cell lines?
Sure.
That might be
obviously, we limited ourselves to the main clearance mechanism, which is LDL uptake. But of course, you could also look at the general level of the free cholesterol. You could look at the multiple different assays, actually. But this would bring even more of the complexity, and this is very tempting to do, and definitely we want to look into it, in particular for the ones that popped up to be very interesting to follow up and to understand their biology behind, actually, from the perspective of combination therapies, for example.
Great, thank you. Well, I think with this we can conclude the session. I hope everyone enjoyed the session, and we thank all the presenters again for really great presentations. Thank you.
Thank you.
Session, and we thank all the presenters again for really great presentations. Thank you.
Thank you.